Laparoscopic surgery was the great technological revolution in surgery in the 1990s. It was developed to reduce the invasiveness of surgery dramatically. With some procedures, minimally invasive surgery has resulted in superior outcomes such as improved survival, fewer complications, and faster return to functional health and a productive life. Laparoscopic surgery then paved the way for the great technological advancement of this decade known as robotic surgery. Technically, robotic surgery or remote computer assisted telemanipulators is what robotic surgery is known as. Just remember, these systems are not true robots since they don't function independently of human control. Instead, they merge physician knowledge and skill with industrial robotic technology, which 3D dimensional visualization systems and computer technology all in one. The initial concept of robotic surgery was developed by the military in hope that surgeons could operate at the site remote from a battlefield. While there is some clinical research being done on remotely performed surgical procedures, the practical application of this vision has not come to fruition yet due to high cost, transmission delays, and medical and legal issues. Instead, robotic surgery is now making a major impact on the field of minimally invasive surgery in hospital operating rooms worldwide. With that being said, though, we do know that they are doing telesurgery from other locations, but it's not practiced very often unless it's an emergency situation due to the fact of not being there, also lag with communication and so forth. A robot is a sophisticated machine developed to perform specific tasks. Robots are known as mechanical devices that can be pre-programmed. It's programmed to perform commands, either set by technology instruction or by human instruction. Most robots are used in factories, but with advances in technology, robots are functioning in agricultural, construction, retailing, and of course, as we know, in the medical field. A machine is defined as a robot if it features some degree of mobility. It can be once programmed or it's programmable. It operates automatically and it's able to perform a large variety of tasks. Robots are classified by generations. You have first generation robots, which are simple mechanical arms without any artificial intelligence. They just perform precise repetitive motions at high speeds for industrial applications and require consistent oversight. So they cannot function at all on their own. They have to be consistently overseen in order to perform tasks. Next, you have second generation robots, and these incorporate a level of AI or artificial intelligence. These machines include pressure or tactile sensors, some type of vision and hearing, while not requiring constant supervision, but occasional monitoring is necessary. Next, we have third generation robots, which include autonomous and insect robots. The autonomous robot works independently without supervision by human controllers or an overseeing computer. The insect robots are controlled by a larger central AI computer. So they're controlled by computer technology by themselves. And then we have fourth generation robots, which are not yet fully developed, but they will be distinguished from other generations by their ability to learn, reproduce, and evolve. Eventually, the intelligence of these robots will exceed the collective computing power of every human brain on the planet. So pretty scary. If you had to classify the Da Vinci or the robot that we use in surgery, it is a second generational robot. Those machines have tactile sensors. They do have some vision and hearing, which we talked about, sensitivity, resolution, binaural hearing, and so forth. But they do require supervision, not constant, but it has to, occasional monitoring is necessary. So ultimately, the monitoring comes from the surgeon sitting at the console. So it's monitored throughout the entire time of the procedure. Surgical robots improve surgical patient care by helping to overcome limitations in human precision and reliability. Although surgical robots are increasingly complex, they still require a surgeon to control and input, primarily by remote control or voice activation. In the future, autonomous robots will operate on people without human interaction. Robots will help control the cost of healthcare not only by replacing expensive surgical personnel, but also by enabling surgeons to perform surgical procedures from a distance. Another cost-saving benefit is shorter period of convalescence resulting from minimal invasive procedures performed by robots. The Da Vinci surgical system ignores hand tremors and keeps manipulators steady. With advances in robotic technology, the surgeon may perform a surgical procedure from miles away, which we've talked about. The surgeon can remotely control the robotic arms at a computer station in Washington, D.C. for a patient in a robot located in Las Vegas. Performing a surgical procedure in real time at a distance is termed telesurgery. However, like discussed, the major obstacle of telesurgery has been a time delay between the surgeon's hand movements and the robotic arm's responses. So let's look at some terminology that we discuss when we talk about robotic surgery. The first term is known as articulated or articulation. This is actually broken into sections by joints. So when we move our wrist, we are articulating our wrist. Many robotic arms have articulated geometry, right? We talked about this, known as Cartesian geometry, and the versatility is measured in degrees of freedom. So what is degrees of freedom? It is the number of ways that the robot manipulators can move. The majority of manipulators move in 3 dimensions but have more than 3 degrees of freedom. So they actually have around 6 to 7 degrees of movement. So 6 to 7 degree joint movements that can move in a manner similar to human wrists. Next, we have binaural hearing, which is the ability of humans and robots to determine the direction from which sound is coming. Humans have 2 ears that provide this ability. Robots are given 2 sound transducers to provide the ability of the hearing. Degrees of rotation. This is the extent that the robot joint or set of joints can move clockwise or counterclockwise above an axis. Expert systems. This term is a method of reasoning AI used to control smart robots. Next, you have manipulators. Manipulators is the technical term for robotic arms. Resolution, which is the extent to which a machine, microscope, or human or robot can differentiate between 2 objects. Sensitivity, which is the ability of the machine or robot to see in light or detect weak impulses at invisible wavelengths. Telechair, which is the name given to the remotely controlled robots. It's just known as telechair. Robotic surgery is telechair surgery. Telepresence refers to the operation of the robot at a distance, meaning the operator is situated in one location, usually miles apart, as the robot is on site with the patient. And telesurgery is just doing robotic surgery in general. When we look at the design of the robots are designed to deliver better patient care through more precise and accurate surgical intervention. However, as I've mentioned, I kind of have some issues with this. The device that consists of the robotic device itself consists of a manipulator and a console. The manipulator is the large 3 or 4 arm device that hovers over the patient during surgery. The arms can hold and move up to 2 to 3 instruments plus a stereo telescope that transmits the images. So that means our system consists of 3 components. You have the component that holds the camera, the component that's the surgical cart, and then the surgeon console. The camera itself, again, provides the surgeon with a 3D view of the surgical field, including high magnification and resolution. The surgical cart itself holds the robotic arms, 3 to 4 robotic arms, where all the instruments are inserted, which mimic the movement of the surgeon's hands, wrists, and fingers. These instruments can only move when being manipulated by the surgeon. They have to use the console controls or the foot pedals, and those console controls are known as master controllers. So all of the movement is dictated by the master controllers and the foot switch that is used by the surgeon. Many of you are getting the degrees of rotations as well as the actual degrees of freedom confused. The robotic arm has degrees of freedom, which allows that pivoting, turning, and flexing motions. So these are like 7, you have around 7 degrees of freedom to move. However, the degree of rotation is the ability to turn or pivot on a 360-degree axis. So what they look at when they develop these robots and they use the geometrical system, they develop on a 360-degree axis, which is known as degrees of rotations, but the actual arms themselves or the tips of the instruments move on degrees of freedom, which allows them to pivot and turn and flex. And so these are articulated or jointed sections, and you have around 6 to 7 degrees of freedom. It just depends on the year or the, not the year, but the actual model of the robot. So if the Da Vinci, we have older models and newer models, so depending on the model that's being used at the facility will be dependent on how many degrees of freedom that the arms or the instruments move around. As we discussed in class, we talked about some of the advantages and some of the disadvantages of robotics surgery or remote manipulation. So first off, the Food and Drug Administration has cleared robotic systems for adult and pediatric use in urologic procedures, general laparoscopic procedures, gynecologic procedures, general thoracic and cardiothoracic procedures. There are specialized systems that are being developed for neurologic and orthopedic surgery as well. We usually use what we call stealth navigation or orthopedic navigation surgery, which is kind of a robot. However, it's not the same as the Da Vinci. So what are the advantages or benefits of robotic surgery according to the facts that they list? So we know that the benefits incorporate both laparoscopic and open surgery when we do robotic surgery. Like laparoscopic surgery, robotic assisted surgery minimizes surgical trauma and improves cosmetic results. Some reports have documented a decreased length of stay, less post-operative pain, faster patient recovery, and faster return to normal activities. Robotic surgery also offers surgeons the increased range of motion of open surgery without the potential unsteadiness of the surgeon's hand. Also, 3D capability returns depth perception, which is lost in traditional laparoscopic surgery. And avocation of the robotic surgery believes it significantly reduces the technical challenge of laparoscopic surgery itself, enabling more surgeons to embrace and advance in laparoscopic. We also look at the fact that it's a 3-dimensional vision, which I'm improved or talked about is improved. You also have improved dexterity, right? Less tremors. You have better grasping of the instruments, better degrees of rotation and so forth with manipulation because the patient is under pneumoperitoneum, they're insufflated, so there's more room inside the abdominal cavity than with open surgery. It talks about increased surgical comfort, the telesurgical capability, but here are some of the other advantages that we talked about in class, right? We talked about the fact that it effectively allows the surgeon to perform these procedures in a confined space. It also has the operative site through 3D imagery. But then we talk about disadvantages. So what are the disadvantages? First of all, one of the major things that they don't discuss is the learning curve. There's supposed to be an on-site coordinator at every facility that uses Da Vinci. However, that is not true. They might have a Da Vinci team, but most surgeons literally go to, they leave the hospital and get 1 day's worth of training, or they go and they will meet up with a surgeon who specializes, let's say, in GU robotic surgery, and they will work with them for the day. And then they come back to the facility and then they start practicing robotic Da Vinci surgery by themselves. So hopefully the staff's trained very well, to get the room set up, drape the robot, test everything, make sure everything's working properly, and then it just kind of falls down to the surgeon's hands while they're sitting at the console. Just remember that the actual robot itself cannot be docked until the trocars are placed. So the surgeon will scrub in beforehand, be sterile, will drape the patient, do all this, prep the patient, then scrub in, drape the patient, and then place the trocars. And then they will push the draped robot over to the surgical field, dock it, and hook up the trocars into the robotic arms or manipulators. Then once all that's set, the surgeon will then break scrub, and then he or she will no longer be sterile, and they will sit at the console. So when I talked about advantages, let me kind of touch base on the disadvantages. I said learning curve. Another thing that you need to be aware of is the fact that the patients are under anesthesia for longer periods of time. Usually these procedures take longer. Also, some other things that we look at is the fact that with robotic surgery, it is very, very costly. Despite the benefits of robotic surgery, the system is expensive. So you're looking at over 1 million. Actually, it's 2 million now for the newer version of Da Vinci. And according to one study, this translates to at least an additional $1,700 per case. So each time we have robotic surgery, it's usually approved by insurance before we do it. And then another thing that we look at is the surgeon cannot feel the patient's tissue, right? They're controlling those master controllers and that foot switch, so they don't have what we talked about in class known as hepatic feedback. They don't get that tactile sense of what it feels like. So there again, they're losing the ability to start out doing robotic surgery. I was told it takes over at least 200 cases for a surgeon to become comfortable. So for the first 200 surgeries of robotic surgery on patients, it's kind of like a game. You don't really know how well you're going to do or not. The last thing I want to talk to you about, not just with robotic surgery, but also with minimally invasive surgery, is just kind of remember some of the things that we've discussed throughout the semester so far regarding instrumentation. I would definitely remember that, when we are handling instruments, remember with the robotic instruments, they do have a certain lifespan and they will be pulled out of circulation. Also, remember we've talked about how we clean, so we know that the best form of cleaning is to manually clean it first to remove all the tissue and bioburden, and then we wash it and get it prepped, the instruments prepped and ready to be sterilized. So don't forget that. Also, look back over the chapter about how we pre-clean endoscopes and how they have to dry and how we have to test them for leak test them for air and so forth, and that whole process of how we clean the scopes itself. Also, look back to the components of minimally invasive surgery, right? You need to look at the control heads. You need to look at the CCU units, sorry. You need to make sure you're familiar with all the terminology in this chapter. Remember what a pitch is, remember what a yaw is, remember what a roll is, remember some of the terminology I discussed on this slide regarding robotic surgery. It's just important that you understand this as well. I would also tell you to go back and look at the differentiation between turning a light up and the gain and how that effect has on the actual procedure itself. Look at sensitivity, resolution, and how that works. I know that it's not in your book, but I've discussed it in here. Google it, look it up. You should be able to find it. Just remember that minimally invasive surgery is performed using a lens telescopes and long instruments, and they're all introduced through the trocar, which is known as the trocar systems, right? In order to perform the operation. And to place these trocars, we use very small incisions. We also do video-assisted surgeries. The video-assisted VATS, laparoscopic surgeries we really haven't talked about, but these are procedures of the lungs and bronchi, and we'll talk about this when we get down to that procedure, but we've talked about some of this previously with placement of chest tubes and things like that. You also need to remember that, these instruments are insulated, right? And anytime it gets broken or pitting occurs, it disrupts that insulation and can cause patient burns. Just remember that the components of laparoscopic and robotic surgery have to have a light source, a light cable, a camera head, and so forth. Remember, you as a surgical tech and the circulator are responsible for troubleshooting and understanding how this works. The surgical technologist is responsible for handling and maintaining the telescope in a manner that prevents errors. Remember what the trocar sizes are for trocar placement on a pediatric, what size you use, and then what on adolescents and adults sizes that we use, and very minimally invasive trocar sizes. Also remember that the robotic system is very expensive and it uses valuable resources, so it's our job to understand how that works. We know that robotic technology is modified and refined, and us as techs and nurses have to continue to advance our skills and knowledge to keep up with it. As with any advanced technology system, nurses require specialized training. Nurses have to learn the setup, operation, maintenance, and troubleshooting of the system for the minimally invasive equipment as well as robotics. So all of us, the nurses and surgeons, we train together when we're dealing with minimally invasive surgery. Just remember, prior to any procedure, the perioperative nurse prepares the 3 robotic components: the surgeon's console, the medical monitors, and the robotic arms. We're sterile, so we're setting up and sterilely draping the robots and sterilely draping the camera and light cord and sterilely draping and troubleshooting and making sure that we pop the drape in properly so that the robotic wheels that the instruments snap into can turn and load the instrument properly. So there's a lot of troubleshooting that comes into play when we look at this stuff. It's very important for you to go back through this chapter, reread everything, understand, how minimally invasive surgery and robotic surgery works. It doesn't seem like it's very in depth, or it doesn't seem like it's very hard surgery. I know you've heard me mention that a robotic surgery working with the Da Vinci can be kind of boring. The setup is not. However, when you're in the case, you just kind of sit there and don't do very much. But sometimes it's the simplest cases that become the most difficult for us to understand because we don't have a lot of hands-on capability with the Da Vinci. So please go back, read this chapter, understand everything. Go back again and reread through endoscopes. Know the difference between flexible and rigid scopes. Know why we perform flexible scope cases over rigid. Remember we do them for biopsies and things like that. So just remember that you have to focus on, when you're taking the test, the certain word in the sentence that might make it a little hard to understand, but it's that one word, that trick word that is going to have you select the right answer. So you need to understand all that.